Good afternoon, everybody. I'm Dr. Jacqueline from Tawam Hospital, and thank you for joining me this afternoon. So, my topic is it focuses on induction of labor, particularly in low-risk women, which is one of the most common interventions in obstetrics. So, as most of us know, it is the artificial stimulation of uterine contractions prior to the onset of labor, and with an aim of achieving vaginal birth. Now, while induction can be life-saving when clinically indicated, inappropriate or premature induction can lead to unnecessary complications, mainly prolonged labor and poor maternal experience as well. Now, this quality improvement project was conducted in a tertiary maternity unit between December 2022 to July 2024. And our aim was to evaluate the existing practice, identify any gaps involved, and implement sustainable improvements in the management of induction of labor in low-risk pregnancies. Our standards were guided by both the Department of Health protocols as well as the NICE guidelines. So we have seen that induction of labor rates have been steadily rising globally as well, often exceeding 25% in certain maternity units. Similarly, our hospital initial audits also noted a rise in induction of labor cases. So, evidence shows that induction of labor without any clear indication can increase the risk of failed induction, operative deliveries, cesarean sections, as well as maternal dissatisfaction. So, the NICE therefore emphasizes that induction of labor should only be offered when the benefits outweighs the risk, and that the woman must be fully counseled and supported throughout the process. Now, let me highlight that as per the NICE guidelines, the key indication for any woman with a low-risk pregnancy is a prolonged pregnancy, which means that the pregnancy exceeds more than 41 weeks. In these cases, you can offer induction of labor between 41 to 42 weeks, and this further reduces the risk of stillbirth as well as neonatal complications. But it is important that routine induction of labor in low-risk pregnancies before the gestation of 41 weeks is not recommended. Now, there are certain other indications that might apply as well when we see a low-risk cohort, which mainly involves pre-labor labor rupture of membranes at term in such cases, where the labor does not spontaneously start within 24 hours. Or you may have maternal requests coming in, but they again require thorough counseling on the risk, benefits, and any alternatives involved. And there could be history where you have rapid labors or precipitate labors, wherein you have logistic concerns where the patient is living quite far from the hospital and they don't have quick hospital access. So in our project, what we did was an initial audit from July to December of 2022, followed by a re-audit between January to June 2024. And we had a multidisciplinary quality improvement team, and we applied the model of improvement as well as PDSA cycles for our intervention. Now, our interventions involved four things. Firstly, the regular departmental meetings to discuss the audit findings in the first place. Structured educational sessions for junior as well as senior obstetricians. Again, we had our labor room staff involved. We had the midwives involved as well. And an enhanced patient counseling with the use of visual information leaflets. We also introduced standardized care pathways checklists and further integrated these into electronic documentation as well. Now coming to our results. Our major point was the timing. So timing plays a very vital role in ensuring successful outcomes. Any induction before the 41 weeks, especially in low-risk women, that is women who have no medical or obstetric comorbidities, this is generally not recommended as per guidelines, as I mentioned. And why? This was because of early induction leads to higher rates of failed induction, increased use of oxytocin augmentation, further risk of higher cesarean section, and maternal dissatisfaction. Now, when induction is appropriate, we are using cervical assessment for Bishop score, cervical ripening either by prostaglandin or mechanical methods, and we may even need the use of oxytocin infusion for augmentation, definitely along with continuous fetal monitoring. So our hospital, prior to any intervention, we noted that there was a 34% rate of unindicated inductions, and mainly this occurred prior to the 41-week mark. This highlighted the need for stricter guideline adherence. And I'm happy to note that after the involvement of all the interventions, the unindicated induction of labor fell dramatically to 7%. Talking about the second most important, the complications. So we have maternal complications such as uterine hyperstimulation, failed induction, increased cesarean sections, postpartum hemorrhage, prolonged hospital stay, and fetal complications such as fetal distress and meconium aspiration, which are related to induction of labor. In our baseline audit, we saw that it was at a relative high of 18%, reflecting inconsistent practice. And after implementing the protocol and guideline aligned pathways, we saw that this complication rate fell to 6%. But this is particularly within the low risk group. The results of the other parameters which we are looking at, firstly, adherence to the guidelines. This rose to 91%. Cesarean section in the low risk group dropped from 24 to 17%. Maternal dissatisfaction, which was at 59%, owing largely to the prolonged labor as well as the poor communication. The turntables and rose to around 82% of maternal satisfaction. Staff awareness of protocols again increased from 55% to 92%. Now, this demonstrated that a consistent evidence-based practice can improve clinical outcomes as well as patient experience. Now, when we compare our practice to the literature, we see that there was, in 2019, Mughlu had confirmed that rates of stillbirth beyond 41 weeks decreases significantly with induction of labor. And Bolbian in 2016 found that there was no increase in cesarean section rates when induction is offered appropriately. Further, there was a trial called ARRIVE done in 2019 by Grobman, which suggested that there could be certain benefits of elective induction at 39 weeks. However, NICE guidelines have strictly said that there has to be cautious evidence-based approach to this, especially because there could be differences due to healthcare in terms of healthcare context or patient demographics. Now, together, all these studies reinforce that adherence to the evidence-based timing and indication optimizes outcomes and prevents unnecessary interventions, reduces unwanted complications, and promotes safer childbirth. To conclude, I'd like to say that following the NICE guidelines as well as the DOH protocols improve the safety, efficacy, as well as satisfaction associated with induction of labor in our unit. And unindicated inductions and complications decreased while maternal satisfaction and staff compliance increased. And embedding evidence-based standards supported by education as well as MDT collaboration increases and creates a sustainable improvement in obstetric care. Thank you for listening. I will